Thank you, everyone, for joining. My name is Josephine Moe, and I'm at RNAO Home Office, joined by President Carol Timmings, CEO Doris Grinspun, Arlene De La Rocha, who is our 2016 Hub Fellow, who is shadowing Doris today. And we also on the line we have Region 1 members, Region 1 Representative Debbie Kane, as well as Lori Jennings, the members of Region 1 as well. So I just want to quickly walk through. If you've joined the webinar, you should be able to see the presentation that takes up most of the screen, and on your right side, there will be a chat box. If you don't see that yet, then locate the chat button. You can click on that and it'll open up the chat box. We'll be primarily using this to receive your comments and questions. So at any time, you can submit your comments and questions. But we have designated times of webinar where we will address these. Also, some of you might be gathering on location to join this webinar. So if you could just send me a private note to let me know how many are in your group, that would be great. Our attendance is looking fantastic so far, so we just want to kind of see how you're participating and get a full picture of it.
And how they send your notes?
Yes, so the chat box, you can just type anything there, and we'll...
So the first question to see that you can test the chat note is to send to Josephine, yes, I'm here with 6 people, yes, I'm here with 15 people, and if you can add, I'm here in a hospital with 5 people, or I'm here in a coffee shop with 10 people, or I'm here in wherever place you're sitting, in a primary care site, wherever you're. And I dare need to say in a public health unit with 15 people, 20 people in public.
30.
Exactly. So that we have a good idea of our wonderful attendance. Thank you very much. We do have over 50 people already, so that's pretty amazing without even your notes. And likely it will continue to go up, so that's fantastic. So maybe the remarks first from Region 1 that really got us going into this because they were the key organizers of this event, please.
Good afternoon, and thank you everyone for joining. This is Debbie Kane at the in Windsor, and I'm thrilled to have so many people participate. And I really want to start by thanking Lori Jennings, who is the Sarnia Lambton Chapter President, and it really was her magnificent idea to have an online opportunity to get an update, knowing that many of us are busy and it's difficult for everyone to get together. She suggested the format of the webinar. And thank you to Crystal Hepburn, our Windsor Chapter President, and to Eddie Aldershaw, Adam Kent President, who have been wonderful in supporting pulling this together. And I will say much of it happened over or just after the holidays, which is a busy time. So thank you so much. As you all know, Mind the Safety Gap is a report that addresses the needs for a transparent and evidence-based interprofessional health human and for Ontario. And we all have a little different experience in our own nursing world, and we really welcome this update from Carol and from Doris. So thank you all for being here.
Anyone else from the region that would like to chime in before we go on? Thank you so much, Debbie. How about our new chapter chair?
That's you, Crystal.
Thank you very much. And once again, we would like to go ahead and let Lori know how much we appreciate her time putting this together along with Josephine and everybody involved. Thank you for considering this opportunity for us to get the word out, knowledge that you're going to share with us today on the Mind the Safety Gap.
Thank you. Excellent. So let me give you some background. This report took about a year preparation. It came out of the AGM 215, where member after member after member, many of them, stood at the mics to speak about not so much the challenges that they were experiencing at places, not so much about being replaced or seeing colleagues to be replaced, but actually what they were seeing with patients, and that they felt, in a summary, if I can summarize it, that patients were shortchanged with this killing of their care. So once members were really very persistent and passionate about that, it didn't become anymore a matter of anecdotes, but a matter of us making a commitment that we will take this issue on in a organized way, in the terms of looking at all the evidence, looking at what was happening with human resources, looking at what the minister was in back then already patients first agenda, and where he wanted to see the province moving, looking at did this match or didn't match at all with what needed to happen, and then put base to what we were recommending. So we started the work very soon after the AGM of 15. That must have been in likely June that we started, after next, where we heard more around the province similar themes. And then we look at 3 parallel streams of what needed to be looked at. One was an analysis of what the government was saying in terms of their health system priorities. And if you look at the Mind the Safety Gap report from page 7 to about page 10, so 7, 8, 9, and 10, all of that really is a very thorough systematic analysis of the government priorities for the health system transformation. Following that, we looked at the nursing priorities to advance such a health system transformation. And in looking at that, we used a model that I will show you soon, but within that, we needed to look at skill mix, we needed to look at models of care delivery, etc. And so that is when we came to the issue of the profile of what nursing was having at the time. RN workforce was at 96,000. RPN workforce was at 39,000, and P workforce was at 2,400. At the same time, you had more complex patients with less predictable and less stable outcomes and environments, which really required, as per the CNO standards of 214, an RN workforce. And then, of course, less complex patients with predictable outcomes and stable environments. In those settings, we would look at a greater increase for RPNs, because some of those environments, as you know, for example, long-term care, really is not RNs or RPNs that are science, but is unregulated care providers. And then, of course, MPs to build and expand on their own competencies as per the CNO standards of 216, and the 4 specialties of primary health care, pediatric, adult, and anesthesia, with regulation 275 and 94, but really to free up MPs from the shackles of anything that prevented them to work from their full scope and capacity, regardless of the model, primary care or hospital care, where they were delivering care, because as you remember, we have succeeded through our RNO's evidence-based advocacy to have MPs admit, treat, transfer, and discharge patients in hospitals. Then this past year, we succeeded with attending MPs in long-term care. So really is to free up MPs from the shackles, i.e. to allow them to prescribe controlled substances and some other aspects that we have ongoingly responded to the college and are now pushing the ministry, likely with good potential for controlled substances to now forward, and other aspects that we're pursuing on the NP file to move forward, as well as independent and in prescribing with our mind putting the phone on mute, please? Then we thought, well, from time to time, and this was past minister, Deb Matthews, the first one that we had a long, quite strong discussion with her. Luckily, we have not needed to have that discussion on the topic, I will say, with Minister Hoskins, but the issue that nurses are interchangeable. Well, nurses are all important, no doubt about that. They're not interchangeable, and NPs are not interchangeable with RNs, and NPs are not interchangeable with doctors for that matter, or with RPNs, nor are RNs with RPNs or NPs or doctors, and not are RPNs, as sometimes the public may get confused with, unregulated workers. All the three categories of nurses are important. The question is where, how many, and for what purpose. So that's when we look, and that's slide number 3, on the numbers, so no one actually put the wrong story, but actually a factual story of RNs, NPs, and RPNs within the different sectors. And when you look at that slide, you can see that with the exception of public health, there has been an ongoing decrease of RNs in all the sectors, and then an ongoing increase of RPNs in all the sectors, and NPs have increased primarily in primary care, and if anything, we would like to increase even more NPs in primary care. But the concerns, whether it relates to hospital care, that has seen significant decreases on the numbers of RNs from 83.3 in 2005 to 78.7 in 2014, or community care, home care, where we have seen a decrease on the RN side of 82 in 2005 to 70% in 2014. That is absolutely outrageous, quite frankly, in the view of our board, RNAO, and its members, and many at the government level, in the face of increased complexity, and when you are looking at a government and a minister that wants to move more and more patients to community care, and yet community care and hospital care both have been de-skilled of the necessity of RNs that can really look for the complexities of patients in those sectors. So that gives you a picture of the numbers, and that drove for us the policy agenda in terms of the redesigning health system around the needs of patients to optimize quality and outcomes and maximize return on investment. The minister saying shift of the complexity of patients in hospitals, complexity in community care and long-term care, which we have seen for the last many years. And that's where it comes the issue of enhancing scope of practice for RNs, including RN independent prescribing, and enhancing the role of public health and primary care for the sake of the system, and I would suggest also of home care. So the first aha moment when we were looking at all these materials and where we looked at the policy agenda of the government was that the plan of putting patients first, or later on even Bill 41, really had no focus on health human resources. It was a focus of structures, and at best structures, really not much about what clinical services will look like, and therefore zero focus on what the health professionals needed to be to deliver those clinical services. Professionals, whether RNs, RPNs, or NPs, do not deliver clinical services to structures. They deliver that to the people of Ontario, whether it's in the streets of our communities, in their homes, or whether it is in schools, or whether it is in hospitals, wherever, is to the people of Ontario, not to the structures that are formed, and so those were serious shortfalls on the report and shortfalls that we very much took on. To make it even more complex, some organizations at the time, and perhaps a bit less now, thanks to the work of RNO, I would say, and to a certain extent also of ONA, were engaging in reorganizing models of care delivery to really meet the budgets. So, okay, we need to cut this amount of money from the budget. Well, then let's replace this number of RNs with RPNs or RPNs with unregulated workers. Let's create these so-called team models that is going really to functional nursing of the 70s, which we did away for outcomes. And let's really have these teams deliver care. The problem with that is to juxtapose this with the U.S., for example. There are two big differences. Number one, RNs supervise other health professionals in the U.S. In our country, across jurisdictions, RPNs, RNs, and NPs are independent in their practice, so you don't have that oversight even if you put teams of people. Number two, if one looks at the trends in the U.S., if anything, the U.S. is moving to all RN in most of their, at least, acute care facilities and by and large in hospitals. And they use other health professionals to augment that care. So it was fascinating to look at the one hand in the literature, one hand what's happening with different models in other countries, especially across the border, where they will, quite frankly, sanction our RNs if we don't take care of keeping them. Yeah, absolutely. They come and they take them. So it was a mismatch of what organizations, not just the minister was doing, but organizations were doing vis-a-vis, at the very least, RN workforce. As we say in the slide, we have seen this picture before, and organizations and governments call it the low-hanging fruit, right? Let's do for the budget whatever is the easiest, so we get the numbers that we need. And some companies, quite frankly, some consulting companies, including Ernst & Young and others, have actually a model where you plug the numbers, they give you the saving, and then the list goes on, right? We saw that movie before. I was, at the time, director of nursing at Sinai when one of the companies, led at the time by Michael Bechter, who is now a big friend of nursing, actually basically said which model you want, here is savings you will get. So again, nurses, whether it's RNs, RPNs, or NPs, do not deliver care to structures. They do not deliver care to budgets. They deliver care to the people of Ontario. Yes, we need to manage budgets, but there is way more than one way to manage the budget. And as you have seen, SickKids, I don't think is deficient in their budget, nor is Mount Sinai. And that's where the recommendation based on the literature that Carol will realize all RN staff in tertiary quaternary hospitals comes about because the type of patients that are there, they are not asking the nurses, can I help you meet the budget? They want their care and their outcomes the best that they can be. The issue is that many times budgetary constraints are driving decisions that are actually moving away from evidence rather than making sense of evidence, and that's when we start to see compromised quality, safety, and optimal patient outcomes, and a disconnect between patients first and what organizations were doing, at least, to what patients need. So in slide number 6, you will see that RNO took very seriously and very successfully some of those issues. The issue, for example, of trying to change as an exercise, it was called. We are just trialing out in neonatal intensive care RNs with RPNs was absolutely ludicrous. And Carol and I had one of those nights, a very important conversation for me Karen had worked in that sector. I had not. I was horrified. And I was horrified about a couple of things, about that it can happen, or horrified that a nurse can say we are just.
One of the explanations we got was that we are just, those babies in there we're just fattening them up in the NICU.
In the media.
Yes, and yeah, and so of course the media certainly picked up on that as well in terms of, this was not consistent with their understanding of the vulnerability that would be in this kind of setting. And as Dorothy, as a nurse myself, I've worked in NICUs, and often those babies are that are waiting for adoption and were very vulnerable, continue to be vulnerable because they may have been compromised due to the mother having had multiple addictions and so on. So it was a perfect example of an explanation being given that actually did not have the best interest of a very vulnerable infant in mind.
And actually these kids were waiting to go to yes, they were not going back home.
They were for adoption.
Yes.
Yes.
Yes, so you're totally right.
That's right. That's right.
So in any case, that's when we sent, I actually was on vacation at that time, and all I could see when I saw that front page in the newspaper is sent a tweet that premature babies are not an experiment, and of course the next call was to the minister, and then the minister put a stop, and we were successful to put a stop. But we shouldn't be in that situation. We shouldn't need, as nursing leaders, I'd rather have a nurse leader, and my board would rather have a nurse leader calling Carreño off the record and say, I am pushed to do ABC. Can you help in your own way? We always find ways, whether it's for chief nurses or whether it's for staff nurses of any category of nursing, we always have a way to actually intervene before something like this needs to evolve into an embarrassment in the media. So that brings us to us and the very active, proactive, and yes, at times aggressive, purposefully interventions that we have had and that we will continue to have to basically protect patient care. Through RNAO, the action alerts to stop iron replacement and implement the recommendations from the report, which Carol will summarize. Almost by now, it's like 23,000 responses, including calling from an interprofessional HHR plan, which, by the way, RNAO put as its first recommendation, a moratorium on nursing skill mix, and changes to stop the fragmentation, stop iron replacement, Queen's Park on the road activity that we went to visit MPPs, active media and social media presence, and of course, the many other activities that you have seen and that you feel free to ask us any of them, including what ended up happening in London that we will not expand, but that you are all aware because of the media. So we basically concluded the report, and let me tell you a bit about the report. And before we move to, I will review trends and models of care delivery, and then Carol will move to the recommendations. So you can see that diagram there. This is a diagram that, in our view, positions health system effectiveness at best. At the foundation of it, timely access to quality care and person-centeredness. And within that, of course, you can see why we're advocating so much that the system in ECHO be centered around primary care with the arm to public health and population health. Why is it that we want to enhance also home care? Why is it that we want to use hospitals for what hospitals do best, which is very complex patients? et cetera, et cetera. And for this timely access to quality care and person-centeredness, we see 4 key pillars. First, a health human resource planning, which the report of Patients First didn't have. Second, interprofessional practice that is optimized. Third, full and expanded scope of practice utilization. Fourth, an evidence-based practice and policy. And on this one, we focus only on the first arm to the right, human resource planning. Because if you can look at the others, interprofessional practice, we have many activities, both educational and a best practice guideline dedicated to that. Full and expanded scope of practice, you will see that in one of the recommendations, both for RNs and for NPs. But we have done tons of work on that as well. And of course, evidence-based practice, there is no other shop in the world that has done the richness of work of RNAO. So, mind the safety gap in health system transformation, reclaiming the role of the RN. The title came because of our realization that the only huge losses for patient care was actually the trends on health human resources on the RN workforce, and that the government had ongoingly, either purposefully or ignorantly, both of which will not be good, misguided the public in saying, oh, we don't have less nurses. We don't have less nurses at all. We are increasing the number of nurses. What they were not saying, and that now they have a much better understanding, but are still not openly, doing all that they need to do. They are doing some of the work, not all, is that, yes, we have no less nurses, but proportionally, we have much less RNs. In fact, we are the worst RN per population in this country for the past year. So the title, it was purposefully. It was not to diminish the importance of RPNs. It was not to diminish the importance of NPs. It was to say those two categories, certainly on NPs we are increasing as needed. RPNs, we better watch it because they may end up staying without work if we continue this way, when patients will stand up to say, I need the right skill mix, my bedside or street side, when I am in the care of nurses. So the conclusion was an urgent call, first of all, for an interprofessional HHR plan that would follow a transparent, evidence-based and engaged process, to reorient the health system within community-based care, as the minister was saying, but to move the resources accordingly, because if not, we were not getting what was needed. Increase public transparency, as the minister says and the premier says we want to see. Provide coordinated and integrated service that match population health needs, which we are not to this day. Monitor health system performance and improve accountability, including from organizations towards the masters of funding, because basically organizations were doing, and to a certain extent many are still doing whatever they please to do, to ensure the appropriate nurse skill mix utilization, to provide organizational models that deliver an advanced continuity of care and not disintegration and not gaps in service, because by design, when you have models of care delivery that have 3 people, an RN, an RPN, and an unregulated provider looking after me even in one shift, no one knows me well, quite frankly. And let me tell you, I was in a place that luckily for our colleague that passed away was an all-RN staff. That RN was there because of the nature of the care. It was an all-RN. If it's a stable patient, it's fine that it's an RPN, but give that RPN the whole care of that patient, not a piece. Give that RN the whole care of that patient. It makes the whole difference for a patient, whether in ICU, whether in palliative care, and whether in another serious situation. Maximize and expand scope and really move to evidence-based practice, and luckily at RNO, again, as I said, we are leaders on that.
Okay, thank you, Doris. So on slide 12, another important emphasis in the report was really shifting from an illness-focused healthcare system to a true comprehensive health system, and noting that this actually requires whole-of-system planning. So that looks at other parts of the system beyond acute care. So the report addressed the need for robust public health services from a health promotion, primary prevention point of view, enhanced coordination in primary care, which of course we know is foundational to our health system, a greater emphasis on the social and environmental determinants of health, and finally, health equity, the recognition that there are unfair health disparities currently in our province, and that there's a lot we can be doing and must do to ensure health equity in terms of our population outcomes. So all to say that effective nursing skill mix and organizational models of care, of nursing care, are actually key to delivering on the vision of patients first. So the next slide actually shows really the provincial trends, and I think Doris has referenced this, that we are seeing in the province at the same time that we have the lowest RN to population ratio. We are seeing increased complexity in patient needs, and we are seeing an over-reliance on an illness-based care system. And we're seeing a greater RPN share in the workforce. It rose from 21.5 to 28.4% in the last decade. And you can see that that is really the wrong trend when you look at increasing complexity of care. As Doris mentioned, there are absolutely places in the system, stable patients, where the appropriate caregiver is an RPN. But when we see increasing levels of complexity, that patient must have and deserves and will need care by an RN in order to achieve the optimal outcomes. In terms of evidence, when we look at skill mix, the evidence showed very clearly that by replacing RNs with less qualified personnel, we're not going to see the outcomes we're looking for. And the evidence certainly bore this out absolutely to be true. We see more mortality, increased readmissions, a greater incidence of pressure ulcers, pneumonia, postoperative infections, upper GI bleeds, cardiac arrests, medication errors, lengths of stay, and transfers of care. And they're all very much indicators going in the wrong direction.
And just to add to these references that are here, and I would like to include that next time that we update this slide, Linda Aiken did a study now for the UK with other countries, and just released it at the end of 2016, and it's even more shocking, actually, than what I thought, because basically her conclusion is that the addition of non-professional staff, now that's the UK, so please, I take it with respect, because for me RPNs and for us RPN are professional staff, but in the UK professional staff is URN, right? They don't have RPNs. But what she looked is at what's happening in the US and other countries, and she said the addition, so not even replacement, the addition of non-professional staff to the mix does not improve nursing care, even if it's more hours. So basically her conclusion was stick to RNs when that's what you need in acute care and in complex care environments.
Very compelling evidence. Thank you, Doris. On the right-hand side of this, in terms of what we're seeing currently in the skill mix by replacing RNs, we're actually seeing less of the very thing that we really want to improve. We're seeing fragmentation of care. We're not seeing continuity of care. Quality of care is going down. Patient safety is becoming increasingly a concern. And very importantly, patient satisfaction with their care. We want to put patients first, and with the current evidence is saying patients are not satisfied with the current model. Doris referenced a few minutes ago the model of total patient care, where the provider, whether that is one RN for more complex patients or one RPN, provides that total care to a small group of assigned patients based on that patient's need, based on stability, predictability, and complexity. Unregulated care providers in this particular model support the nurse with delegated tasks, but it is under the supervision of either the RPN or the RN. So what gets lost in the current models of care and what's being driven by what we're seeing in terms of RN replacement is a loss of all the things we know that translate into good patient outcomes in care. We're losing continuity of care. There's lost efficiency. We're seeing compromised safety and compromised quality. And quite frankly, patients aren't satisfied. They're speaking out, and they should speak out, because they deserve and need the highest quality of care. So when you see the team models that are being driven reportedly by fiscal pressures, see multiple providers parceling out tasks and care, as if it was just a functional way of going and not looking at the total patient. So in primary nursing, as we've said, Mind the Safety Gap talks about there being the most appropriate level of provider assigned to act as the primary nurse throughout the entire process of care, and that is providing all aspects of the nursing care. And Doris, it's beautiful to see that this is actually attributed to you and the work that I know that you have done in this area.
Yeah.
And that the most effective means of ensuring this is through the primary nursing care model. So, this slide, and in the interest of time and wanting to hear your questions, I think speaks in another way with yet additional evidence and sources that when we have team-based models that fragments out the care, you see very adverse impacts. You see more hospital-acquired infections, time spent on administrative tasks rather than direct patient care. There's fragmentation across the units. It's very hierarchical. One provider doesn't really know what the other is doing. Inequitable workloads. Liability goes up, not only for the provider, but liability and risk for the patient. And regrettably, we get avoidable adverse events happening. And we get less of what the patient needs, less time on psychosocial care, very clear accountability for that patient care and for those outcomes. Lost continuity across care providers, and quite frankly, lost productivity. So the evidence is there, absolutely. So before moving into the recommendations of the report, we thought we'd take a few minutes. I know questions and comments have been coming in. So Josephine, if you would be so kind as to we'll take a few minutes and you can read out for the participants some of the questions that have been coming in, and Doris and I will respond.
Sure. So I'm sure that some of you have seen the comments that are being submitted in the chat box, which is great. I'll just read out some of the ones that we've received so far. Someone asked, have these sources aligned with cost factors? Money always captures the attention of decision makers.
First of all, please know that there is quite a bit of research on the RN effectiveness, not only on health outcomes, but actually on money outcomes. When RN care results in less complications, that means less money. The higher the complications, the more the patient stays more days in a hospital or more days under the care of a nurse in home care. So actually they are aligned, and there are studies on cost effectiveness that very clearly show that. The problem doesn't so much lie on the evidence. The problem lies on the either, as I said before, whether it is by colleagues or by CEOs or by CFOs, chief financial, or by governments, on choosing to ignore the evidence or being ignorant of the evidence. But the evidence is there. Even if you Google it, you will find it. So you don't even need to do a systematic review to find RN effectiveness on cost, and you will get tons of articles.
And someone else submitted the comment that not only satisfaction, but the experience of patients is also affected.
And the experience of patients and of nurses. So let me tell you, Carol shared her personal story with ICU or NICU. Let me share in 2 seconds my personal story of why I fell in love with primary care and why I developed the expertise on it. So I actually was working in Israel for many years, team nursing. In fact, you go to the shift, we are talking in the 70s, right? You go to the shift, the first thing that you did is you open this thing of tasks to find which ones were your tasks. You gave them, I was the med nurse, and then the wound care nurse, whatever, right? And then that was it. And then we was a couple of RPNs and me, and I worked very closely with RPN and loved working with RPNs, except the only problem I had is when I would stop to talk with the patient, I was turning to see if someone was watching me, because there was no time. That was not my job. I needed to move with the cart with the meds, right? Yeah, this is what you see in long-term care today, a lot. It kills other places. And then all the sudden, well, not all the sudden, then we moved to the U.S. Well, I moved to this unit at the University of Michigan in Ann Arbor, where it was primary nursing. I didn't have a clue what they were talking. In fact, I was on my first shift quite afraid that I was going to be it for the patient. The RPN had some stable patients. I had my whatever number of patients that were more acute in rehab, but very acute. I was it. And then I kind of remember leaving the shift and saying to my husband, this is heaven. This is heaven. I'm bathing the patient. I can talk with the patient. I'm giving, right? And I never could look at the satisfaction, not only on the face of my patients and their families, my own satisfaction. And those of you that have done total patient care ever, or that have done primary nursing, you cannot even conceive how can it be like, do you have a patient having 5 physios coming? Do you have a patient having 5 OTs in the same shift, 3 coming to do different things? Or in the same shift, 3 doctors that will talk about what they, right? They have a primary doctor, they have a primary physio. They ought to have a primary nurse. Why are we less when we are there 24/7? So thank you for that comment. You really enlightened my heart.
Okay. Another comment received was that team models were archived many years ago. So sad that we see this model of care being resurrected.
Absolutely, and thank you for pointing that out, because particularly when the evidence points absolutely in the opposite direction. And I think we're figuring out that what's driving that is absolutely not the patient experience, not the patient outcomes, but rather poor decisions made based on their interpretation of cost. So I really think that it's important. You make a very valid point, and I can't encourage you enough that you speak out about that. I think the more that we as nurses and providers speak out about this, the more we will be heard. And we're speaking out for nursing, and we're speaking out in the best interest and well-being of the patient. So thank you for saying that. I just encourage you to echo and amplify that very comment everywhere you go. Thank you for that.
Someone responded to Doris's experience, and they said, that was my experience as well. It is amazing.
Yeah, it is really nursing. Yeah. It is really nursing.
It really
the
is.
Other, to me, the other is not nursing, is checking list. Checking list.
Yes.
Not nursing.
Yes. Good.
Thank so you, again, for the last comment, for the colleagues, speak out on that. Speak out on that, absolutely. And where, yeah.
Okay, so Josephine, there are a couple more. Do we have, I think, Doris will take them? Yes, thank you. Very good comments and questions.
Okay. So the next comment. I work in an outpatient cancer clinic, and our manager is implementing RPNs in the last 2 years. We have never had RPNs. It has always been RNs. These patients are complex and radiation, etc. Our manager doesn't listen to RN concerns. What can we do to try and change this back to only RNs providing care? We are not even seeing our follow-up patients and therefore are not able to continue with our therapeutic relationship.
My suggestion is give a call, send a note to Josephine. Let's meet and talk. I know of a couple of places where this is happening. Absolutely, we can mobilize together through RNO, so you don't risk your role, your job, your employment, but we can mobilize to actually make a point on this. You know, outpatient care it used to be our inpatient care. It's like home care. It used to be inpatient care. Mm-hmm. And the patients that come there when they come for cancer treatment or whatever other type of treatment, or for that matter in primary care, deserve the same type of continuity. I would not have shared with whichever nurse, whichever person, and I went yesterday because I needed something in my primary care side, with whoever that comes to me, that I was losing colleagues. You know what I mean? Even if it's primary care, we have a right to have that relationship that is continuous, because if we cannot share that with someone, then you become ill on something else, right? It is something that is a pain in your heart because of that, or whether it's that you have cancer and have ongoing treatment, we have the right to continuity.
Mm-hmm. Doris, I just want to add that when Doris and I were doing our fall tour, you know, it was very important that people came up and shared those real lived experiences they're having, whether it's in outpatient or emerge. And honestly, that kind of information, that RNAO can be so effective in terms of, you know, taking those issues on and really advocating and moving forward with this kind of evidence-informed policy work and really affect important change. So without putting any risk at all to any of you who may bring these scenarios to our attention, it just actually, it's very rich information for us, because it just, we have the evidence, but you can actually surround that with the narrative, the narratives that are happening each and every day across this province. So thank you so much for sharing that, and I would encourage you to follow up with Doris's request of emailing it to Home Office. Time for one more, Josephine, maybe, and
okay, so the next comment is, the onus rests on the CNO and governments to ensure that RN's positions are not being taken away because of money or the mentality fit into our organization's culture mentality for talented RNs.
So when you say CNO, the person that is writing, could you tell us, are you saying College of Nurses of Ontario, or are you saying Chief Nurse? Just to clarify the question so that we can...
or CNE. Is it a Chief Nurse Executive?
They have
So they will. So if you, let me answer quickly. If you think it's the CNO, College of Nurses of Ontario,
college. They just said college.
the college, yeah. Well, don't expect that. Sorry to tell you, don't expect that. The College of Nurses of Ontario will not get involved on this. We have discussed that. They don't see it as a regulatory matter. They should see it, in our view, as a patient safety matter, which is the issue of the college. And I would encourage you, as Carol did with other comments, send a note to the college. See us. Send a note to us saying we want you to approach the college. The college also needs to feel the heat on this blurring. I mean, if you remember some years ago, they completely blurred to the disadvantage of nurses and patients, and at that time we heard not only from RNs but from RPNs. They completely blurred at one point, taking the stable and predictable and the complex. Out of pressure, quite frankly, they put it back. And today, if you look at the slides, the issue of complex versus stable is there. So they need to feel, when the college says that their role is to protect the public, I totally agree with your comment, it is. Unfortunately, you need to put your voice either into an email to us that we can share without your name or whatever comments. As for government answer will be, or used to be, these days will change more because of basically them understanding the evidence more. But it is more manageable in terms of the more they understand the evidence, the more they will intervene with organizations, as they did with St. Joe's at the time when they wanted to replace RNs with RPNs. My suggestion is go to visit your MPP, either within the RNAO Queen's Park on the Road or the visits that we do, and I am sure and I hope you are all RNAO members. Get involved with your chapter, whether it's Region 1 or others, and visit your MPP, or go by yourself. And you can speak with an MPP in confidence also, say, this is my organization, this is what's happening. They will never, ever compromise your job because it depends on your vote. But they will have the stories. And all MPPs need those stories to do their work because that's their bread and butter. So again, speak out with your families, with your friends, with your community, in your church, in your synagogue, in your whichever ethnicity, religion, wherever you are, speak out. In the supermarket, only don't speak with your patients about this simply because they don't need the stress of this conversation. But for that, I again strongly suggest for patients wear your RN pin. Every year when you sign RNAO, and by the way, if you're not a RNAO member, please sign online. It's only $260, and if you are a non-member, it's only $170 for the whole year. Sign RNAO. Every single year you get an RN pin because we know you leave it on the fridge, on the car, on the whatever. You need to have it on you so patients can say, oh, you are an RN, and you will say, I'm a very proud and knowledgeable RN.
Thank you, Doris. So I think in the interest of time, we're going to, we've sort of woven in some of the recommendations of the report, but I'm going to do a quick synopsis of the recommendations, and then I think as importantly is Doris is going to close by speaking about the incredible progress that has been made. In fact, I have to say, sitting here this evening, thinking from the first time this report was launched to now, how incredibly gratifying it is to see the impact that this report is having on health system transformation in this province. So let's take it from the top. The first recommendation in the report was really calling on the Ministry of Health and Long-Term Care to develop a provincial evidence-based interprofessional HHR plan. It's great to release a bold vision of patients first. It's great to have the legislation, but we're going in opposite directions if we don't really have a comprehensive HHR plan to bring this vision to reality. As Doris said, structures are one thing, but you must have the HHR plan in place in order to make this vision a reality. The second is a call on the ministry and local health integration networks to issue a moratorium on nursing skill mix changes until this plan is in fact in place. And we continue to advocate on this point, which reinforces the first recommendation. The third recommendation is directed at LHINs, that LHINs mandate the use of organizational models of care delivery that actually advance care continuity and avoid care fragmentation. So once again, that would be primary nursing care. The fourth recommendation is that the ministry legislate an all-RN nursing workforce in acute care effective within 2 years of the release of the report for tertiary, quaternary, and cancer centers. And in the appendix of the report, those are listed in Group A and D. And so, as Doris mentioned, this is about those healthcare institutions with the most complex patient care needs. And we contend that an all-RN nursing workforce must be legislated in those settings. And within 5 years for larger community hospitals. So they're the time horizons that the report calls on, and that we also work together to look at an increased number of NPs and clinical nurse specialists practicing to their full scope of practice. And once again, you know, we do hear all the time, particularly in long-term care, primary care, and other settings, where increasing the number of nurse practitioners could make such a difference to the workforce and to patient outcomes there. The fifth recommendation is that LHINs be required to implement that all first home health care visits be completed by an RN. We believe that RNs, and the evidence is there to show that RNs do have as a core competency an ability to do that first comprehensive assessment of that patient who is discharged home, and this is of the patient and also understanding the importance of the environment that that patient is going home to, being able to assess the level of family support, food security, all the factors that will mean that this transition home will be successful. And based on that RN's assessment, the care plan and the appropriate care provider will be recommended. The sixth is that the ministry, LHINs, and employers eliminate all barriers and enable nurse practitioners to practice to full scope, including prescribing controlled substances and acting as most responsible provider in all sectors, implementing their legislated authority to admit, treat, transfer, and discharge hospital inpatients, and utilizing fully the NP anesthesia role inclusive of intraoperative care. We are currently seeing that there are actually being barriers constructed within institutions. NPs have the authority to do this, and yet institutions are putting in place barriers through policies and, quite frankly, nonsense.
To protect physician income.
That's right.
That's what it is.
And so it's imperative that this be looked at and that those barriers be removed. The seventh recommendation is that the ministry legislate minimum staffing standards in long-term care homes, that there be one attending nurse practitioner for every 120 residents, 20% RNs and 25% RPNs, and 55% personal support workers in terms of the staffing mix. And finally, the eighth recommendation is that LHINs Sorry?
This number now is 4,100. It's like this.
Okay. So Doris is just updating the number for this, that LHINs locate the 4,100 CCAC care coordinators within primary care. And by that we mean physically located. Don't have them. We realize the transition with the change at with CCACs ceasing to exist, and with the care coordination functions, it's not satisfactory to just stop within LHINs. That we believe that those care coordinators must be located within primary care in order to carry out the health system coordination and navigation that is key to their roles. And that continues to be an advocacy point and a recommendation within this document. So I want to then, Doris, as we're transitioning over to you speaking to the progress, I want to say, and am very pleased and actually privileged, and you all should be as RNAO members, that RNAO has been recognized on a number of occasions. First of all, our very clear reference in the Patients First discussion paper, and then recognized by Minister Hoskins at our 91st AGM in May of 2016 as very heavily informing the whole reform and transformation agenda. I think RNAO has always been recognized and seen as a very credible voice, advocacy voice, because of our attention to evidence. We're not making this up. Everything that is in this document and our advocacy positions and policy positions are very evidence-informed. And it was very, I would say, rewarding, but also I think we should be proud, and it's kind of fueling the very important evidence-informed work we are doing to see that we're being recognized as a huge group of providers in this province as actually informing one of the most important health system transformations that has happened in this province in many, many years. So on that note, Doris, as president of RNAO, I also want to, and I like to at every point on behalf of the board and our members, to thank you for your incredible courage and leadership, and home office staff for all the incredible work that has gone into this report and into the advocacy and policy positions that RNAO is taking. Because I think patients and clients in this province are counting on us for that, quite frankly. And so, Doris, can you take the last few minutes to speak about the progress?
I will, and let me say that there is no courageous CEO without a courageous board. So that's very important. So just following up on the recognition of Minister Hoskins at our 91 AGM, let me tell you that he has recognized the report, the Mind the Gap report, the ECHO report, in all the information that he has done with his own Patients First agenda. Bob Bell, the deputy, knows ECHO right out. There is very few individuals that are top bureaucrats at the ministry, or whether it's the Premier Minister or the opposition leaders or their health critics, that if you tell them ECHO RNAO, they don't know what it is, because that's from where the idea of Patients First come. But we're focused today on Patients First, on Mind the Gap, Mind the Safety Gap, not on ECHO. So I will not provide you with the full progress on ECHO, because also on that there has been many steps forward in what RNAO is influencing at the government. In relationship to Mind the Safety Gap, the first recommendation about developing a provincial evidence-based interprofessional HHR plan. So you can look at the launching of DATCO, led by the ministry and RNAO, on an event at McMaster with a report that went to the ministry, and with the first request asking for a independent table where we will be able actually to have ongoing discussions on this issue. a legislated RNO nursing workforce in acute care, tertiary, quaternary care, and cancer centers. The deputy not only was with our board, which he was, but he also sent a response to RPNO, a very small response that I was copied, where he said, and I don't have it in front of me, but basically said, well, actually it's copied here, thank you, where he said the same that he had said to our board. He said being very familiar with quaternary care because he used to work at UHN as CEO, as president and CEO. Patients classified as having tertiary or quaternary needs who are in acute care hospitals require RN care, he wrote to our PNO, and as do most cancer patients in acute care hospitals. So this is very important. Feel free to use it. Feel free to quote him because I do have that email. I was receiving that email. In fact, the deputy did call me when he sent that email, and I was very impressed with his ability from his own experience to articulate that, and of course also not only to our board, but actually broader than our board to the nursing community, including to others that perhaps were not as impressed with that. I would hope that we have our RPNs in the teleconference, and I would hope that you understand that it's not about your role, and if we have MPs, also it's not about your role. It's about what patients need in this province. It's about that these patients are unstable, if patients are with unpredictable outcomes, if patients are in unpredictable environments, what they need is an RN. That's the expertise. That's why we moved to baccalaureate entry to practice. If patients are stable, whether it's at home in a community hospital or in primary care or in the care of an RPN with continuity of caregivers, so not chopped care again, not fragmented care, that's okay. If we are talking about access to primary care, if we are talking about moving patients smoothly through the system, we ought to have NPs admitting, treating, transferring, and discharging patients in our hospitals. We ought to have NPs as attending NPs in long-term care. We ought to have NPs in primary care, whichever the model it is, whether it's NPLCs that RNO was at the forefront and the negotiator on the first 25 NP-led clinics, or whether it's attending NP that RNO pushed and succeeded and we co-led that initiative with the government, or whether it's admission, treatment, transfer, and discharge, which was negotiated in closed doors between RNO and then Premier Dalton McGuinty. And it's because that's what patients need. It's not because the NPs are more beautiful than the RPNs or the RNs. It's about what patients need and about not having job models but continuity of care. So we have succeeded with those aspects. You will hear more in the month to come, including at our AGM, of course, and at Queen's Park. You will hear significant progress, including on the issue of the LHINs and their mandate, including about eliminating barriers not only on control prescribing for MPs, but other barriers, on including hopefully the minimum staffing in LTC homes, which today by and large have an, I would say, an all unregulated staff model. And again, it's not because unregulated staff are not nice people, but that's insufficient for the level of complexity of our seniors and other people in long-term care facilities. And you will hear that CCAC coordinators, 4,100 of them, will be employed by the LHINs, and we have agreed with that, but located, embedded in primary care so that they can work within interprofessional teams serving the people of Ontario, especially those with complex needs. So that's in addition to the 4,000 RNs already working in primary care and the 2,500 RPNs, 2,500 NPs. So just picture a group of almost 12,000 nurses working in primary care. If you add to that independent RN prescribing, what that will do to the next aspect on patients' care, and actually RN prescribing is not within the progress here in the report, and we need to add it on the slides, because independent RN prescribing not only is in the mandate letter of the Premier to Minister Hoskins, but actually is moving ahead beautifully, and you should hear about that as well very soon. The same as controlled substances for MPs, you will hear very soon. So yes, progress, tons of it, more progress. Yes, we are committed to deliver, and for that we need your voice to again echo Carol. All these comments that you sent to us, make them to anybody that you see, and not only health professionals. Go also to your MPP, go to your local media, speak with your families. Your families sometimes need the care themselves. Tell them the differences between what an RN, an RPN, and what an NP is, so they get the care they need at the right time in the right place.
Thank you so much. So that really...
a couple of minutes in case there are questions.
Yeah, I think, yeah. Josephine, if there are any questions, and then I'll turn it back over to, I think Debbie. It was Crystal who's going to wrap up. Yeah.
Beautiful.
Okay, so some questions we've received online. Have you heard how the Ontario Public Health Standards revision is progressing, and how do you see public health nurses fitting into the HR plan?
Thank you for that. So yes, the Ontario Public Health Standards have been going through a process of modernization, and I have it under very good authority that they are going to actually be released in the field for consultation on implementation approaches. So that is going to be happening in early February with an opportunity for feedback to the province, and then a formal release taking into consideration, I would hope, some of that feedback, a formal release to the field in May, and a firm date of implementation of the new standards in September of this year.
Can I add to that?
Please do.
So I do want to add another piece that my president is too humble to say, and is that Carol is in the advisory panel of the minister on the area of public health, and also to end that round, I am in the implementation advisory of the Premier on the issue of, and of the Minister on the issue of the patients first. And one more thing that people may like. On February 13th, we have for ourselves a public health nurse, Cheryl LaRonde O'Gilby, from a Peel Public Health Unit, a star from STARS, coming as full-time staff at RNU.
Wonderful. Great news, Doris. And I believe the second part of the question, Josephine, if I recall correctly, was how will public health nurses factor into the HR plan? Well, I think it's certainly recognized that public health nurses play a very important role in terms of health promotion and primary prevention. And absolutely, we have been recognized in the health transformation agenda by the minister for our expertise in population health planning, health equity, and really advancing health, understanding the broadest determinants of health. I think when you look at the trends in HHR across public health, you will see that we're the one sector within the overall system where the RN, the baccalaureate preparation, has actually gone up a little bit. I would love to see more nurse practitioners in public health, absolutely. But I think you can be quite confident, I don't have a crystal ball, but public health nurses will continue to play a very, very important role in the HHR plan overall in the system and in public health generally.
So to augment that, as you may or may not know, we have several programs where we work very, very closely with public health. Smoking cessation is one, where we work with public health nurses and with teachers, with youth, and now with also indigenous communities. The other one was the obesity panel, BPG, where we had from Michael Creek that really brought voices from the street to the issue of social determinants, to Chio, the president of Chio, yes, but
Alex Monter.
Alex Monter, who brought the other side of the perspective. So when we do our work, whether it is on addictions, whether it is on mental health, whether it is on obesity, we take a very broad upstream approach. Of course, we are also very, very involved we were very involved, and Carol can attest to that, and she was proud of that, on the moving of the safe injection services. And not only that, the then medical officer of health requested that same day from us that we develop a guideline, which we are in the process of developing. And then there are many, many other examples. At the federal level, we have partnered with a group of stakeholders, including CNA, including the AIDS Nurses Association, on a federal court case. We can send to the colleagues the press release on that, on a safe needle exchange in correctional facilities at the federal level, and in fact we are taking on the federal government on that, and many, many other initiatives that really bring to the forefront different aspects and the importance of an upstream approach.
The other thing I would add, and I know we're running out of time, but I think it's an example also of the opportunities that get presented to nurses across the system. And since this last question was about public health nursing, one of the changes that we're starting to see across the province is an enhanced understanding of the contributions that public health nursing makes to the overall wellness of the population. And we are seeing increasingly reaching out from our primary care partners with whom we absolutely share the same communities that we provide care in, looking for ways that we could partner and recognizing the contributions public health nursing is making and new innovative approaches to areas of perinatal mood disorder and working with that postpartum mom in the community, 18-month well baby visits, really looking at an enhanced role that aligns beautifully with the Ontario Public Health Standards, and yet really, you know, our areas that RNAO has been working as well to advance. So by way of summary, I just want to really encourage you all, having participated this evening in this webinar, to join RNAO if you're not members, to get involved more in RNAO if you are members, and to really find your voice in advancing much of what we've talked about tonight. And thank you so much for taking the time out of your evening to be a part of this important webinar.
And on that note, before I pass on the phone, to join or to encourage others to join, www.rnao.ca, www.rnao.ca. Am I saying it right, Josephine?
Yep, our website.
Yes, I did.
Yep.
Also put it big there for them. So that's very, very important. The more the numbers, and let me celebrate that we are ahead already of the same time last year. We ended up last year with 41 strong. We will end up with 41,000 even more stronger, and with your assistance, the more members and the louder our members, the more we achieve the results we all need.
We want the closing remarks by Crystal, is it?
Yes.
Crystal, are you on the line?
No, it's Lori saying the...
Oh, Lori, my apologies.
Who gets credit for putting this together.
All right. Over to you, Lori.
Okay. Can everybody hear me?
Yes.
Yes.
Perfect. I'd like to thank Doris and Carol for providing us with this update and overview the RNAO Mind the Safety Gap report. As registered nurses, nurse practitioners, and student nurses, it is important that we stay informed and, more importantly, have a voice at all levels of health care and reform. Our collective voice has a vast history of contributing to the shaping of our healthcare system through the advocacy for healthy public policy, legislation, nursing practice excellence, and so much more. I'd also like to thank Crystal Pepper, President of the Windsor Essex Chapter, Betty Oldershaw, President of the Chapton Kent Chapter, Debbie Kane, our RNAO Region 1 Regional Representative, Josephine Moe, Executive Assistant to Doris, and all of the Region 1 members who helped to bring this event together. And most importantly, I'd like to thank all of you for joining us today for this most informative presentation. Thank you.
Thank you.
And we had an amazing crowd of almost 60 people on an evening, 65. So we should really say thank you for taking the time and for seeing the importance of this, and keep giving it echo, give it voice, and ask many others to give it voice. Because with the progress we have already made, trust me, we will make even more progress. And by the way, in case you wanted to know about how Dr. Vanessa Borkowski is doing, given all the media exposure she got, she is the chief nurse at Humber River Hospital, doing a magnificent role there, and really producing very excellent results. So at the end of the day, as Carol said in one webinar, being outspoken doesn't mean you end up in a worse place, or doesn't mean your career ends. Actually, that's far from the case.
Thank you, everyone. We'll be signing off now. Good night.
Bye now. Have a good evening.
Bye-bye.
Bye.